Hi everyone and welcome to ABCs of Anaesthesia, and again we have a special episode here where we're interviewing Faith for some exam practice, and we're going to put this on YouTube and a podcast as well. So hello Faith, welcome again.
Hi Lahiri, thanks for having me back.
No worries. Hey, you're dressed up? Is this part of the getting ready for
Yeah, I thought I would take a note from the last podcast and thought it was a good idea to get in the zone.
No, very good. I feel like we should have a dress standard. Unfortunately, I'm not really living up to that. Hey, so one thing I asked James last time was, is there anything in particular he's doing for preparation up to this weekend? Is there anything that you're doing for your pre-exam preparation?
I suppose just trying to stay as sane as possible.
Yeah.
Yeah, following from previous advice, and I've heard it talked on your podcast, making a big effort to get enough sleep, exercise, eating well, all the usual. Yeah.
Are you a studier up to the exam, or are you a taper off person?
It's funny, I'm normally sort of to the last minute kind of cramming, but this time around it's been such a long slog, since August, that I just feel I've got to the point where I'm just really saturated.
Yeah, fair enough.
And I mean, I'm still going through things, but I haven't got that sort of keen deadline that I felt for previous exams.
Yeah, okay, yep. No, that's fair enough. Yeah, you're right. It is a really long slog. It's been 12 months, right? Or longer, eventually.
Well, 9 months since the written.
Yeah.
But
okay.
a lot longer for study time.
Yeah, that's a long time. Well, yeah, why don't we get started? So I'm going to give you a bit of an interesting stem. You've just started a lap collie in a small hospital. You're the only theatre running, and there's, say, 2 wards in this hospital with no ICU, and a small ED that's minimally staffed on the weekend that you're working. And then your next patient, a 16-year-old male with type 1 diabetes, comes in feeling very unwell for an elective inguinal hernia repair. He is 70 kilograms and 170 centimeters, and he's on insulin for this management. He's dry retching and really doesn't look that great. And the question is, how do you approach this? And I'll give you 2 minutes. Yeah, how would you approach this?
So this is a young male with significant endocrine disease for general surgery in the what appears to be an urgent setting. So my management, I would initially go and see the patient and do a rapid assessment in an A to E approach to...
The one problem you have is that you've started a lap collie. So let's say this incision...
Oh, right, yeah.
So what are you going to do to sort that out?
Yeah, sorry, I didn't take it into account. So I'm in the middle of a lap collie, and I've been told of this patient who sounds quite unwell. So depending on my resources, if I had another anaesthetic reg or specialist...
So you have no registrars and no other specialists?
Okay, so I'd speak with the surgeon to find out the urgency of the procedure. And then...
As in the lap collie, the general surgeon?
Yeah, to find out the urgency of the it's an elective inguinal hernia.
Yep, and you're currently, there's pneumoperitoneum in the lap collie, they're dissecting away. So you say you're 45 minutes half an hour, 45 minutes into the lap collie.
All right. So this doesn't sound like...
They've got another 40 or so minutes to go.
Okay. We've got an elective patient next on the list who's unwell with what is probably diabetic ketoacidosis or sepsis. And I would be saying at this stage to the surgeon that I have concerns for the next patient on the list and that he needs to be properly assessed, optimized, resuscitated before going ahead with his elective surgery. I would then, at a suitable time if my patient on the table is stable, then I would call to the physician in ED to get a bit more information about the patient and make sure they're being adequately resuscitated.
Oh, so this patient's just in the day procedure admissions area.
Right, okay. And you said there's a small ED but no ICU.
Yep, and there's just a couple of resident second-year doctors and an intern, maybe 3 of them throughout the hospital, ED and the wards.
Okay. I would ask one of the available residents or interns to go and see that patient in the day surgery unit and do an assessment, find out if they get a history, and resuscitate them appropriately.
Now, because they're residents, I'm gonna probably hazard a guess that their expertise level and experience is going to be potentially really not adequate for what you've said was a DKA. So what do you reckon? What can you do based on that?
I can ask if there's an available medical registrar, or speak to the on-call endocrinologist.
You can definitely speak to the on-call endo. There's no more senior than a second-year doctor available to help you in person.
Okay.
Now, obviously, I'm making this a really tricky situation, and you've got limited resources. You've got a patient on the table. You just can't be at 2 places at once.
Yeah.
Yeah. So how are you going to possibly get around this dilemma?
Well, what I could do is transfer the patient to the bay, just so that I had a closer eye on them. And then the second year doctor could go and assess the patient at the bay, but report back to me, and that would perhaps be a bit better line of communication than going back and forth from the day procedure unit.
Yeah, that's exactly what I'd do, I reckon. I reckon I've got a patient who's probably, lap collies are generally stable. I could be in there and have another doctor or my nurse interchanging with me at various times, because this is a bad situation. You want to leave a patient on the table, but you have to do something, because this patient, like you said, it's probably DKA. They're vomiting. They're looking really unwell. I need to get some stuff done very urgently for this patient. So I completely agree with you. And have you been asked questions like this where you're asked to prioritize very stretched resources?
Yes, I've been asked similar questions where it's involved mobilizing the patient, or occasionally getting someone to monitor your patient in a desperate situation.
Yeah. Okay. So let's say that situation is an airway emergency in PACU, and you've got a lap collie on the table. How do you manage that? Just to stretch this example.
Well, it depends on the gravity of the situation, but if the patient's in extremis in PACU and there really is no one else around to help, then although it's not technically, you are your priority is the patient in front of you, but if they're stable, your anesthetic assistant is happy to monitor them, then I would go to PACU to assess the patient, resuscitate them on the proviso that if there's any change in condition of my patient in theatre, that I'll be immediately called and come back straight away.
Yeah, I go one. Keep going. Sorry, you go.
And if that patient in recovery had an airway problem but was stable enough to be transferred, then it would be preferable to bring them to the bay at least, just so you were a little bit closer.
Yeah, fantastic. And there's all levels of urgency, like you mentioned, like depending on how bad whatever this problem is. And one of the other things I remember, one of the seniors telling me is like, "Oh, look, this is tough. You really can't be in both places at once." I'd tell the surgeon, stop, hand them the aramine syringe, or to make them unscrub so they can't operate, and say if the blood goes below 100, give them 1 ml of this. And that was one other way to kind of manage that situation. Again, I don't know what the exam answer is, but I've been asked this question just like you have, and I do think about this and what I would actually do in real life. But yeah, so let's keep going with this case. So let's say that you now are getting the patient into the bay, and you're managing your patient adequately, and you're trying to resuscitate this other patient with the help of a resident and a nurse. Anything else that you want to put into place?
So you said there's no ICU there?
Yep.
So at this stage, if the patient looked really unwell, I'd be considering retrieving this patient out to a suitable facility. So I'd be putting that ball in motion and making contact with the retrieval team.
Fantastic, great. You know, the end point for this potential DK is ICU, and you need to arrange that right now while you start some stuff going. But let's get back to this case now. So let's say the lap collie finishes remarkably, surprisingly quickly, and now you can focus all your attention on this sick patient, the 16-year-old male, type 1 diabetic, who's now looking pretty unwell. Tell me what your approach to this is specifically.
So I want to know how unwell he is, particularly the degree of shock that he may be in. Mm-hmm. So as I said, I would do a rapid assessment from focusing on his airways, ventilation, his cardiovascular status, his neurological status, and exposure.
Just to give you some numbers, respiratory rate is say 40, saturations are normal, 97% on room air. Patient is tachycardic at 120. It looks like it's sinus rhythm, and blood pressure is pretty normal. It's been pretty normal at around 100, 110. And you've got access now, so you got 2 drips in as well.
He's tachypneic, tachycardic, but with those numbers, I would take a focused history from the patient and elicit how long he'd been unwell for. And inquire about symptoms, including vomiting, abdominal pain, any other GI upsets. And
so what's happened is, it looks like patient was fasting for a while, but was kind of unwell beforehand, but really just wanted this operation to be done. Fasted for longer than required, as well as not adequately, so not taking insulin for longer than was actually advised.
All right. And furthermore, I'd like to know what his normal insulin therapy is, and if he's normally well compliant, and if he knows what his HbA1c is, and what his control is.
Let's say overall 20 units of insulin per day on, whatever management plan. I won't get into specifics about that. HbA, apparently this patient's blood sugar levels have been up and down for the last month. And generally not that well controlled, and the HbA1c is, say, 9.
Although he's young, I would also inquire about the presence of any micro or macrovascular disease, because if he's had very poor control, then he may have underlying cardiac disease or retinopathy, neuropathy, or renal dysfunction.
No problems from your history and examination.
Okay, and then I would like to know, despite other than the fasting, is there any other precipitant? Has he got an infection anywhere else? But part of my examination, I would hopefully pick up on that.
Yep, let's say nothing obvious.
Okay, I would examine him carefully for in terms of his airway. Just although I'm not planning to go ahead with surgery, it's just something I would do, and I'd also do a focused cardiorespiratory examination. But I'm particularly nothing to note. I'm particularly interested to know, other than his vitals, what his other investigations are, his current blood sugar, and I'd send off a venous blood gas to look at his acid-base status as well, and his lactate.
Fantastic. So the current blood sugar, the current BSL finger prick is 30. It's similar on your venous gas. The pH is 7. PO2 is 90. Sorry, let's say the PO2 is 100. PCO2 is 23, and bicarb is 10. What do you make of that reading, those numbers?
So this man has severe metabolic acidosis with inadequate respiratory compensation. I would also like to look at his electrolytes to calculate his anion gap, which I would anticipate to be elevated in this circumstance as well.
How do you calculate the anion gap?
It's the sum of the sodium and potassium ions minus the chloride and bicarb, and a normal anion gap would be 8 to 12 millimoles per liter. Yeah,
sounds good. Now, let's say it is raised. What are other causes of a raised anion gap?
I use the well-known acronym MUD piles.
Yeah, go for it.
So I'm not sure I remember all of it now, but there's various toxins, including metformin, isoniazides, ethanol, ethylene glycol, salicylate.
Clearly the mnemonic hasn't worked, but it sounds.
What's that? No, I know.
The mnemonic hasn't worked.
I'm not going in the order. I'm trying to categorize it into toxins and then pathophysiological effects. So salicylic, can't say the word, salicylic acid.
Yep.
Raised uremia, ketoacidosis, and lactic acidosis can all cause this.
Fantastic. I used to use mud piles and stuff, but then DULE, dual, kind of easily satisfies that for me. So diabetic ketoacidosis is D, U is for uremia, L is for lactic acidosis, and then E is for ethanol and other toxins.
That's probably a better way. Yeah.
Yeah, because I found mud piles was pretty much just lots of ethanols, methanol, and ethanol, and ethylene glycol.
It sounds a bit disordered, doesn't it?
Yeah, I mean, yeah, ethylene glycol, so common.
Yeah.
Good. So that's and this is obviously diabetic ketoacidosis most likely. What is DKA?
Diabetic ketoacidosis is a life-threatening event that happens in usually type 1 diabetics, where there's an absolute deficiency of insulin, resulting in a ketoacidotic state associated with hypoglycemia. So what happens in the absence of insulin, the body's unable to take up the glucose, and as a consequence, there's also a counter-regulating uptake of glucagon growth hormone, which results in gluconeogenesis, glycogenolysis, and then lipolysis, which results in these free fatty acids, and you get your production of your ketones, which leads to acidosis. And then with the hypoglycemia, this leads to an osmotic diuresis, so there's a coexisting significant hypovolemia.
That's fantastic. I like that you've given quite a lot of information, again, quite succinctly. I think this exam is about giving facts. Just saying that it's a life-threatening condition is not enough, but then offering the fact that it has all of these things and processes in rapid succession, I feel, is actual facts on the page. I was having a recent discussion with a trainee about, when you say severity and stability, which is a bit of a catchphrase these days, severity and stability of a disease, and that you assess for that's just giving a structure without giving facts. So, you can then easily go on to give the facts in quick succession. But you explain that really well, so that's great. What is the triad in DKA? Have you heard of that?
The triad is hyperglycemia, a pH of less than 7.3, or base excess.
So metabolic acidosis.
Metabolic acidosis and ketoanemia.
Fantastic.
So
I didn't really care that if you knew that or not, because you explained all of that. I feel like that's a smaller part of it. How about hyperosmolar hypoglycemic state? What's that?
Yeah, this presents very similarly to DKA. That's my understanding, but it can happen when there's a relative lack of insulin. So you still have insufficient insulin to take for your cells to take up your glucose, but because, and this may be my interpretation, that there's because you have a small degree of insulin, that it's more of an insidious onset, but quite typically presents with a much larger hyperglycemia, often in the 30s. And these patients can actually present an extreme shock because of the longer duration.
Yeah, that sounds good. And that's pretty fair. I haven't seen many of these, though. DKA, I think we all see these regularly enough. With DKA, what is the electrolyte picture or imbalance that you see?
With your hyperglycemia, you can get a pseudo hyponatremia or a dilutional hyponatremia. The body often has a deficit of potassium, but because of the acidosis, it may present with initial hyperkalemia.
And why?
Just with the effects on the cellular transport with hydrogen ion exchange.
Yeah, that's right. So potassium swaps for hydrogen ions to try and preserve your pH at a relatively normal level. But that's good. And just to go through that, so the pathogenesis of DKA being, like you mentioned, absolute insulin deficit. Insulin's needed for glucose uptake. It reduces hepatic glucose uptake, promotes muscle and fat deposition. DK is also in response to a stress increases your counter-regulatory hormones. And you mentioned the gluconeogenesis and glycogenolysis. So that just increases glucose even more in the system. Absolute insulin depletion promotes hormone-sensitive lipase in adipose, and that promotes fat breakdown as the alternate fuel source. And then this fatty acid oxidation produces ketones as the toxic byproduct. And then you mentioned osmotic diuresis as well. So osmotic diuresis is caused by hypoglycemia and the hypoketonemia and the electrolyte balance, as you mentioned, urinary loss of sodium, potassium, and chloride, but hyperkalemia due to the acid shift, but a total body loss of potassium. So this is often like, I don't think anesthetists manage this that commonly. It's very much ICU management. Patient presents through emergency, unwell, goes into HDU ICU in that setting. But how would you manage this? What are the principles of management?
Well, I did actually recently do my ICU term last year. And I've obviously revised this a little bit. But the principles are fluid resuscitation is the first priority. This is followed by replacement of potassium with slow fluid titration. And then...
Actually, sorry, you're about to say the list before the detail, which is fantastic. I shouldn't have interrupted. So volume, replace potassium, keep going.
And then commence insulin, and then start dextrose when your BSLs are dropped to a certain level.
Fantastic. So just to rehash, when you've got a lot of things to explain, I give a list and then wait for the detail to be prompted. So volume replacement, potassium replacement, insulin replacement, glucose infusion, and I've also just got here treat the cause as well if there was a cause. So tell me more about each of those in more detail.
Well, fluid replacement would start with 20 mils per kilo bolus, so say a litre of normal saline, and typically the patients are going to be several litres behind and may need quite a few litres. But my fluid resuscitation, my goals would be to fluid resuscitate to cardiovascular improvements and organ perfusion. So I'd be using targeting my blood pressure as a guide. Following this, I would start a slow infusion of, I would use plasma light. I'm not quite sure what, I mean, different hospitals have different protocols, but I started say infusion of plasma light, 100 mils an hour. And then I would titrate in potassium at either 10 millimoles or 20 millimoles per hour in a separate 100 mil bag of saline.
Yep, sounds
depending
good.
on the level of the potassium. And
when would you start it? At what level of potassium? Because let's say they're going to be hyperkalemic.
Yeah.
When do you start it?
I would start potassium once it's less than 5.
Yeah, sounds good. That sounds reasonable. I've got a few different kind of protocols here. So just to go through that volume replacement, I like that you said they're going to be a lot of liters down. So I would give a bolus 20 mils per kilo, and I imagine you'd reassess, give another bolus. But they may need up to 1 to 3 liters in the first hour, another liter every hour for the next few hours, and then you could titrate to your urine output and your cardiovascular parameters and things. And then potassium, like you mentioned, generally speaking, 10 millimoles per hour of potassium is a very safe amount to do, especially if you're monitored. But if there's a severe potassium deficit, I guess you could go to 20 millimoles per liter per hour. Good. So less than 5, when you can start replacement, is reasonable. I've got here 4.5 to 6. And if the potassium levels 3 to 4.5, go at the higher range of potentially even 10 to 20 millimoles per hour. Tell me about insulin replacement.
So my protocol, I remember it starts at it's a fixed rate infusion, and this would be 0.1 units per kilo per hour. And then after a couple of hours, if the blood sugar is dropping too quickly, then I would half that, or if it wasn't enough, then I would consider doubling that rate. I know previously people used to give boluses of insulin, but I don't think that's advised anymore.
That is absolutely fine. And how would you run your glucose, and when would you start that?
So I would start 10% glucose when the sugar had got to less than 15 millimoles per liter. That's when I would add in my glucose. and run that at a fixed rate at 80 mils an hour.
Yeah, that sounds reasonable. I've got here when I'd started at less than 10. I think I've got this from the Royal Children's Hospital DKA guidelines for adolescents. Good. Now, let's say you've treated this patient, the patient's transferred and everything goes well with this patient. And now, because we're on this topic of diabetes, I'm just going to keep chucking bad stuff at you. You see his father in pre-admission clinic the next day for bowel resection for a cancer. He's on an SGLT2 inhibitor. What do you advise him in the pre-admission clinic?
Specifically with the SGLT2 inhibitor?
Yes.
I would advise him to stop taking it 3 doses prior to surgery.
Yep, three doses, was that? So,
yeah.
Yeah, that's fair. So 7, your first.
So if he's having it once a day, 3 days pre-op to stop it.
Yeah, sounds good. So it's like 2 full days before the operation where you don't have it and you have it on the day before. Yeah, that's right.
And then not having it on the day of surgery. Yeah.
Absolutely. Sounds good. And say someone has a morning surgery, just to keep this as simple and as clear as possible. What is your general advice for insulin and oral hypoglycemics?
First of all, it depends the nature of the surgery.
Mm-hmm.
So
this operation, bowel resection.
Okay, so for major surgery, I would advise them, they're not going to be resuming their normal eating patterns, that later that day. So I would advise them to take their normal insulin the day before, including their long acting of the night before, but not to take any insulin in the morning of surgery, not to take their oral hypoglycemics. And with any patient with diabetes, make sure that they're checking their blood sugars regularly. They've got emergency guidelines that they know what to do if they're having a hypoglycemic episode. Advise them to take clear sugary fluid and have someone else to drive them into hospital. And if I was concerned with their control or their ability to understand those instructions, I would consider bringing them into hospital the day before, although this is less than ideal.
That sounds good. Now, so we mentioned oral hypoglycemics just cease them on the day of surgery. In insulin, you can essentially emit or short acting. If you've got a long acting or ultra long acting, what do you do with that?
Again, I have heard different guidelines. Some say take half the dose the night before. Mm-hmm. But from my understanding, I would still add, from the sources I've read, that they still advise on them having the long-acting dose the night before, but not on the day.
That's reasonable. I've seen similar things. I adhere to local protocols. Often the ultra long-acting, I continue at the normal dose, but any kind of medium-acting ones, I can half the dose. But there is variability to that. How about SGLT2 inhibitors combined with metformin? What do you do about those?
In this instance, in previous hospitals I've worked at, we've actually given a script for metformin so that they can carry on taking it whilst withholding their SGLT2 inhibitor. Mm-hmm. And then with regards to the metformin on the day of surgery, if it's minor surgery, I would advise them to continue. But if it was major surgery, then I would advise them to withhold the metformin on the day of surgery.
Mm-hmm. Now, so say the patient arrives on the day of surgery, often they'll take blood sugar levels like you mentioned, and also finger prick ketones. What's the relevance of this, and when are you concerned with ketone levels?
Yeah, so the concern is the patient having euglycemic ketoacidosis. So what I would do in the first instance was to check their blood ketones. Mm-hmm. If the ketones were less than 1, then they're not ketotic. Mm-hmm. If the ketones are greater than 1, then I would check the base excess from a venous blood gas. Mm-hmm. If the base excess was less, i.e. more positive than -5, then that would indicate that they're not acidotic, but they may be ketotic from fasting. Mm-hmm. If the base excess was -5 or greater, then this is concerning for acidosis. So in the first instance, I would be happy.
Why aren't you looking at the pH just straight off? Oh, obviously, guidelines that talk about base excess in preference to pH, or
yeah. I can't give a technical answer, but I think it's just more accurate in dictating whether someone has a true acidosis or not.
You're right. The base excess is the measure of the total acid component of your metabolic disorder. So that's fair.
Okay.
And that's right. So that does actually make sense. So if you have a base excess, that's really the pure acid component. Whereas if you took the pH, the respiratory rate could, or the minute of ventilation could change your pH
Yeah.
quite dramatically.
It's affected by compensation. Yeah.
Good. So your number is, if it's greater than -5, then you may have a problem, or less than -5.
Yeah. So if it's more negative than -5,
yes,
like,
less
then
than 5,
this is worrisome for acidosis.
Sounds good. In our guidelines, we just have a pH of less than 7.3, and they don't mention base excess. But I'm gonna agree with you that seems like a better way to go. Just without, this is not my area of expertise by any means, but that actually does seem quite reasonable. I wonder, it would be, maybe it would be good. You can send me your guidelines later.
This was taken, I think, from the ANSCA statement however long ago.
Oh, excellent.
Yeah, in combination with the Diabetes Society.
Yeah, beautiful. Let's say the operation begins. Everything was fine throughout that preoperative process, and this laparotomy for the bowel resection commences. Then during the operation, the nurse checks the BSL, and it is 20. What do you do?
So we're going back to the father who's having his bowel resection.
Yeah, that's right.
Who has stopped his SGLT2 inhibitor.
Yeah, that's right. Everything has been fine.
Okay.
This patient's also on insulin, which is stopped appropriately, and the sugars have just gone.
All right. Well, in this case, given it's major surgery and he's insulin dependent, I would have already started an insulin infusion.
Mm.
So if the insulin infusion was running, then I would be doubling the rates, or more likely I'd be following the hospital protocols, which gives specific instructions on how much to increase or decrease the rate. And if
how do you make up insulin?
So it's 50 units in 50 mils of normal saline, 1 unit per mil, and in your vial of Act Rapid, it's a minute amount. It's like 50 units is like 0.1 of a mil. So it's a good idea to do it with someone else because it's prone to drug errors.
That's right. One of the pinch drugs, right? Potassium, insulin, et cetera, et cetera. So specifically, rapid vials are really interesting, and they're actually not easy to understand. It's 3 mils of 100 units per mil. And so I've seen lots of errors almost happen based on the complexity of this. Like, first of all, it's 3 mils. That's an odd amount of mils. And when you read 100 units per mil, I've seen people confuse the fact that they might think the whole 3 mils is 100 units because they've misread that. And we're talking about fractions of a mil, that's tricky. So, 100 units in 1 mil, so that's 10 unit in 0.1 mil, that's a tiny amount with a lot of room for error. Even the hub will have a tangible portion of that as well. Fortunately, they've got these insulin syringes with, instead of the mil amounts, they've got insulin syringes with the unit amounts on the gradations, which is pretty helpful. Good. So there's not a maths exam, but 100 units per mil. How many mils do you put into your 50 mils of normal saline?
0.5 mils.
Nice.
Pass.
Pass. The funny thing is, even though I feel like I know this, I will always ask my nurse or my registrar to give me that number independently. And it's a subtle thing, right? It's not like you go, hey, I reckon it's 0.5 mils, isn't it? That's a leading question, and people want to agree with the boss or their colleague. Whereas if you go, hey, what's the number? First of all, they hate doing the maths, so that's annoying for them. And they have, you need someone to actually do the work on that. But hopefully it helps people to get their head around that. Yeah,
that's a good safety check.
So let's go now. You've been a consultant for a few years, and years later, this poor patient now has end-stage renal failure and is being scheduled for arteriovenous fistula formation with the vascular surgeons. What do you want to know on assessment?
All right.
Let's say the patient's 60 years of age now.
Okay. In addition to my usual anaesthetic assessment, I would like to know the background of the patient's renal failure, the cause, and what treatment the patient's on. And also I'll be inquiring about current method of dialysis and symptoms of fluid overload. So asking about wheeze, indicative of pulmonary edema or orthopnea, whether they pass any urine and how much, and any peripheral limb swelling. Mm-hmm. And then I'll take a focused cardiorespiratory history. Mm-hmm. And I would ask the surgeons if there's any particulars for their surgery, if they were happy with the block or not. And I'll examine the patient, looking for, again, signs of fluid overload, any symptoms or signs suggestive of cardiac failure. And I would look at their observations, look at their bloods, particularly at the potassium and the level of I'd like to know what the level of creatinine is, whether it's going to be high, and any other abnormalities, including anemia, electrolyte disturbance. And then I would look at an ECG and potentially some imaging, depending on their history.
Yeah, good. Again, I do like the way you targeted that. You're targeting what I care about with renal failure, what causes it. There's obviously diabetic. You want to know the regime for that, because that's a whole bunch of stuff. Is this patient on fluid restriction, urine output, current dialysis regime? And often you want them to have a dialysis the day before the operation to make sure that potassium's normal or, pretty close to the operation. And then you went through examination findings as well as the investigation. So really, I just want to know the electrolytes and the current creatinine level. And, there's obviously end-stage renal failure, so it's going to be pretty high. But yeah, so I forgot if you mentioned that, but I also meant I do want to know if there's a fluid restriction that affects health.
Yeah, I forgot to say that, and I would usually ask that.
Yeah, exactly. No, that's all good. So again, you got through that targeted assessment really quickly. Again, it really, and you said facts about each of these, which is really great. What is your technique for your block? What are you doing?
I would obtain consent from the patient and exclude any contraindications, establish IV access, and ensure I had appropriate monitoring assistance, prepare my drugs and equipment. Mm-hmm. And then I'll position the patient supine, 30-degree head up. Mm-hmm. Having performed a block timeout, I'd have them look away from the site to be blocked. Mm-hmm. I would prep the skin with chlorhexidine alcohol prep.
What block are you doing, by the way?
Oh, sorry, I'm doing an interscaling block.
Interscaling? Why?
Actually, I'll take that back. I'll do it just because I was preloaded with interscaling in my head. But,
that's not the wrong answer.
No, I mean,
when is it the right answer and when is it the wrong answer?
The advantages of it interscaling, it's technically more easier to do than, say, an auxiliary in a lot of patients, particularly if they're obese. Mm-hmm. The downside of the interscaling is that you miss the ulnar territory, but in a AV fistula, that's not really a problem. Mm-hmm. Other downsides in vascular opacity, they have coexisting chronic obstructive pulmonary disease, then the phrenic nerve palsy may be problematic, and there's a higher incidence of other adverse effects, mm-hmm. including Horner's syndrome and effects of the cervical plexus chain as well, and a higher incidence of pneumothorax.
Yeah, so I mean that's a good point. So the interscaling blocks often miss the lower portion, so you might not get your lower T1, etc., or C7 necessarily. Like you might not get the block there, whereas your auxiliaries and your superclavs will get down your full hand. Whereas if the AV fistula formation is higher up, I guess interscaling will work pretty fine because it will cover that region. Good. So just on that, so again, I like that you had a quick summary of, I forget if you mentioned that there was a professional document on this, but professional document on this, monitoring system, drugs, equipment, consent, IV access. And then you mentioned that one thing which has been a big deal for our procedures and policies with ANSCA, which is in a stop before you block. Many blocks don't have. So you did the block timeout thing, which is a thing that we, it's a big deal that we should be making a big deal before all blocks. So that was great. You do your appropriate, let's say you do the auxiliary nerve block, because they're doing visceral formation down at the radial artery. and the patient starts feeling pain during the operation. What do you do?
I'd ask the surgeons to stop, and I would elicit the nature, severity, location of the pain.
Yeah, sharp when the surgeon's cutting.
Okay, at this point, I would suggest that I usually leave a bit of local anesthetic in terms of my volume so that the surgeons can top it up.
But let's say for this example, you used all of a lot of anesthetic because it was and because your reg was doing it and you were trying to guide them through, and you had to top it up as they failed. And now,
all right. So at this stage, my options are to use systemic analgesia or offer the patient a general anesthetic.
Fantastic.
And it depends on the stage of the operation as well.
Well into it and not ready for suturing yet.
Okay. So I would initially try with systemic analgesics, including opioids and NMDA receptor antagonists, alpha-2 agonists, but it's unlikely if it's really surgical pain that they're going to manage with that. And my option after that would be to do a general anesthetic. Yeah,
sounds good. Now, let's say, I find this kind of process interesting. You know, failed block, whether it's Caesar or regional anesthesia, you go through this whole process of telling the surgeons to stop what you did, offering a general anesthetic, because that's, you know, pretty much a requirement that you don't want people to experience pain. I think there's legal precedent for that as well. And then a combination of local anesthetic by the surgeons, opioids, ketamine, and these are, you know, it's not morphine, this is fentanyl, alfentanil, remifentanil, so they're very fast onset efficacious opioids, ketamine, you know, I might even put in nitrous, even volatile, and also midazolam, so hopefully they forget this period. But these are all the steps that I do, and it's a common bundle of practice that I do for any failed regional type technique. But let's say, so the operation goes without a hitch and it's successful, but you find out the patient is very upset that he was in pain and he wishes to make a complaint. What do you do?
I would go and see the patient and find an appropriate place, appropriate time, and bring a support person for the patient, but also another staff member. And I would listen to the patient and empathize with him, express my regrets as to what had happened. And I would then inform him of the steps to be taken to prevent such an event in future from an individualized and system approach. I would then make sure that the patient had adequate follow-up for his GP and psychological support if required, and document the discussion. And I would then discuss it with my head of the department, as well as in a departmental morbidity and mortality meeting, enter it into a WebES incident report, and contact my MDU.
Yeah, that's very good. What is the patient support person? Is there, besides the patient's family member, is there any other patient support that you could mobilize?
Yeah, there's social workers are quite helpful in this situation. Or if the patient has a religious belief, then sometimes a hospital chaplain can be used.
And there's also the patient advocates in my particular hospital, which is another resource. But so that's great. There's a whole package of care, right? If something goes wrong and a patient's unhappy, you did it. I think you approached that really well. Open disclosure. You created the situation of having a support person, patient advocate, plus yourself having someone there to, I mean, not only potentially help you with the debrief, but also to witness it and learn for themselves, because these are rare incidents and it's a good learning and teachable moment as well. Then you mentioned all the system stuff, Riskman, M&Ms, contact your indemnity insurer as well. And then further follow-up for the patient, whether it's a surgeon, GP, psychological support. So a whole bunch of stuff. And I think, again, you got that out really quickly. That's the end of that. That's the end of the vibe. How do you feel?
Okay. Not bad.
Good. No, I think you did really well. Again, I think your systems are solid. You're getting facts out really quickly. I'm not an examiner. I've got no guarantees, but I just feel like you're, answering the questions really well. And all I've really done is offered you some subtleties, subtleties to the answers. But otherwise, yeah, I'm really happy with that, Faith. Well done.
Thank you.
Cool. When is your exam?
It's in 2.5 days.
2.5 days. Hey, good luck. Yeah.
Thank you.
Oh, well done. Okay, well, I guess we'll sign off there. Thanks very much, Faith. Thanks so much again for being part of this. And yeah, if anyone's got any questions, please email me at abcsofanaesthesia@gmail.com. And otherwise share this with anyone who might be interested. And thanks very much for watching and listening. See you guys next time.